Okay, so that covers some of our reflex findings and physical exam findings with regards to myelopathy. Let's now transition into physical exam findings for radiculopathy. And there's several special tests that we can use to confirm the presence or the absence of radiculopathy. And recall that the AMA guides define radiculopathy as injury to spinal nerve root or roots. So some of the tests that we want to focus on include the cervical compression or SPURLING'S maneuver, and this is described in the AMA guides. Other tests not described in the AMA guides are the shoulder depressor test, the upper limb tension test, and then also the thoracic outlet tests. Now, the AMA guides discuss radiculopathy, and they require the presence of a positive root tension sign in order for the diagnosis of radiculopathy to be confirmed. Now, the AMA guides do not discuss root tension signs for the cervical spine. They do discuss root tension sign for the lumbar spine, but they do not discuss root tension signs for the cervical spine. And all of these maneuvers that I list here for you are different types of root tension signs. The cervical compression maneuver is a root tension sign. Shoulder depressor test is a root tension sign. The upper limb tension test is a root tension sign. And the thoracic outlet tests are also root tension and or brachial plexus tension signs. So I give these to you here as special tests included in your cervical spine examination in the presence of concern for radiculopathy. So let's talk about each of these tests here now in sequence. With the cervical compression maneuver, also known as SPURLING'S maneuver, this maneuver is used in the assessment of disc protrusion or other type of intervertebral foramen compromise. It's also used in the assessment of ligament lesions and also irritation of the facet joint capsules. So this test is performed quite simply. The subject is seated with the head and neck in a neutral position. The examiner interlocks his fingers and places his hands on top of the subject's head, and provides a gentle downward force, and make sure to begin the downward force gently and progressively. Take care not to cause forward, backward, or sideways bending of the cervical spine. In other words, the maneuver is done first in the neutral position. Once the neutral position is completed, then you can add some different variations to the maneuver, and variations include the addition of side bending, the addition of rotation, and the addition of backward bending of the cervical spine. And those additions can be done either singly or in combinations. Now, compression force directed through the cervical spine in a position of rotation is referred to as Jackson's test. In general, we refer to all these maneuvers as cervical compression maneuvers, but the maneuver in extension is referred to as Jackson's test. Now, the maximum cervical compression test, in other words, the test that produces the maximum compromise of the intervertebral foramen, is performed with the cervical spine laterally flexed and rotated to the same side as the lateral flexion, then with the addition of extension prior to the application of the downwardly directed axial pressure. So a good progression to consider when performing the cervical compression maneuver is to first begin in the neutral position, and then to progress to a laterally flexed position, then to progress to a rotated position, then to progress to a lateral flexion with rotation position, then to progress to a lateral flexion with rotation with extension position, this being known as the maximum cervical compression maneuver. Okay, so for those of you that have the PowerPoint presentation, I have a diagram here of how this maneuver is performed, and you can see in this diagram the examinee is in a position of cervical left lateral flexion, and the AMA guides refer to this as the Sperling sign. Now, in the presence of a disc protrusion or other compromise of the intervertebral foramen, the compression of the spine tends to increase the symptoms. And if your examinee reports that this maneuver decreases their symptoms, that may be an indication that the lesion is not due to disc protrusion, but rather is due to some type of a ligamentous lesion, or perhaps even irritation of the facet joint capsules, because compression of the spine unloads both the ligaments and the facet joint capsules. Now, in the case of a disc lesion, compression, any of these forms of compression, whether they're included with side bending or rotation or extension, this will refer symptoms toward the side of the side bending and rotation. In other words, it'll refer symptoms to the side of the intervertebral foramen that's being compressed. Therefore, a report of pain symptoms on the side contralateral to the side of the compressed intervertebral foramen would be considered a non-physiologic finding, or at least it would be a negative finding for radiculopathy. Now, for radiculopathy, the test is positive when the pain arising in the neck radiates in the direction of the corresponding dermatome ipsilaterally. Okay, so there's two components to a positive finding. Number one, neck pain, and that makes sense that if there's an intervertebral disc lesion, a disc bulge, a disc prolapse, nerve root compression, that's going to cause localized pain as pressure on those inflamed and injured structures is increased. But then also it includes the presence of radiating dermatomal pain ipsilaterally. Symptoms on the contralateral side would either be non-physiologic or a sign of some other type of lesion, perhaps a muscular injury. Now, localized neck pain is not a positive finding with this maneuver, meaning that it's not a positive finding for radiculopathy. In order to confirm radiculopathy, there must be the presence of ipsilateral dermatomal radiating pain. Now, this is referred to variably as the cervical compression or Sperling's maneuver. And classically, in the literature, the Sperling's maneuver adds an additional component to these maneuvers of side bending, rotation, and extension. And this involves the examiner taking his fist and pounding on the top of the examinee's head. Now, don't ever do this. I don't know if anyone ever did that to me. I might get up and punch him in the head. That maneuver is not necessary. And that maneuver in itself can provoke symptoms even in the absence of a disc lesion. And it's not a necessary part of the maneuver. So do not pound the top of the examinee's head with your fist. Now, what about the shoulder depressor test? This is another valuable root tension sign. And the shoulder depressor test is performed in suspected cases of nerve root or nerve compression due to foraminal compromise, dural adhesions, or even in cases of facet capsule irritation. Now, to perform the shoulder depressor test, and for those of you that have the PowerPoint presentation here, I have a diagram that shows the application of this maneuver. The subject is positioned generally in the seated position, and the examiner first depresses the shoulder of the side being tested, and then simultaneously side bends the neck away from that side. So for example, if you're testing the left nerve roots, you would depress the left shoulder, thereby stretching and tractioning the nerve roots, and then you would laterally flex the neck to the right to further increase the stretch of those nerve roots across a disc bulge, across perhaps an osteophyte in the cervical spine, or otherwise tractioning those cervical spine nerve roots at the spinal cord. Now, reproduction of symptoms or exacerbation of already existing symptoms on the side being stretched indicates a positive test. Localized neck pain is not a positive shoulder depressor test finding. Doesn't mean that this maneuver does not cause localized neck pain. It can, especially in the case of facet capsule irritation. However, it's not considered a positive finding for radiculopathy. Okay, radiculopathy involves an exacerbation of radiating dermatomal upper extremity symptoms on the side of the nerve roots being tractioned. Symptoms on the contralateral side would be considered either non-physiologic, perhaps, or perhaps due to some other type of lesion unrelated to neuroforaminal compromise. Now, in the presence of a positive shoulder depressor test, you can test the validity of those findings by reversing the maneuver or reversing the provocation that caused the reproduction of the symptoms. So if symptoms are reproduced with shoulder depression and simultaneous cervical contralateral flexion, then those symptoms should be relieved by maneuvers that would then decrease tension on the nerve roots. And this brings up the shoulder abduction relief sign, also known as the Boccotti sign. And I did some research on the abduction relief sign, and I took a quote from a 1981 study in Spine magazine. And the authors concluded that the shoulder abduction relief sign has not been commonly elicited in the past, and the authors wish to bring attention to its value as an indicator of significant cervical radicular compressive disease. So I don't know if you've ever actually seen a person, a patient or an examinee present to you with the abduction relief sign, but I have. I remember in my clinical practice time about 5 years ago when a person who was a new patient, male approximately age 45, came through my front door and had his arm on top of his head. And I recognized that immediately as a Boccotti sign, also known as the shoulder abduction relief sign. And so you can use this maneuver as a validity test. And if your examinee reports increased pain or other type of pain with the abduction relief maneuver, that would be considered a non-physiologic exam finding. And this is an important maneuver to include in your examination protocol, because examinees, they don't know these maneuvers, and they may think that this maneuver is just another exam maneuver designed to provoke pain. And so a report of pain on this maneuver would raise your suspicion for a non-physiologic exam finding. And so for those of you that have the PowerPoint presentation, I have a diagram here of a positive Boccotti sign. And a positive Bocotti sign is considered an objective examination finding, at least according to the authors of the study I quoted in Spine Magazine, that this is a positive objective finding which indicates significant cervical radicular compressive disease. So include the shoulder the shoulder abduction relief sign in your examination maneuvers to either confirm or rule out radiculopathy. Okay, another examination maneuver to add to your template is the upper limb tension test, and this is also a root tension maneuver. And the upper limb tension test is designed to stress the cervical spine nerve roots, the brachial plexus, and the dura of the cervical spine. And in order to perform this maneuver, the subject lies supine, and the examiner applies movements to the upper limb and the neck that progressively stretch the neural tissues. And the key word here is progressive. You begin sequentially to increase the pressure on those neural tissues. Rather than doing this all at once, you want to make sure that you initiate the stretch progressively. So initially, the examiner will begin by abducting and externally rotating the shoulder slightly posterior to the frontal plane. So in order to do this, you have your examinee scoot over to the long edge of the table, and then you take their upper extremity and abduct the shoulder and externally rotate the shoulder slightly below the level of the table, slightly posterior to the frontal plane. And then you stabilize the scapula in depression, thereby beginning the first level of traction of the cervical spine nerve roots. Okay, so we initiate the traction of the cervical spine nerve roots by depressing the scapula. Next, the elbow is passively extended, meaning you as the examiner, you passively extend the elbow, and you wait for a report of reproduction of symptoms. If there's no reproduction of symptoms, then you continue to progressively stretch the brachial plexus and the dura by next supinating the forearm, and you ask for symptoms. In the absence of symptoms, you would then increase the stretch on the neural structures by extending the wrist and then finally extending the fingers. And for those of you that are chiropractors, you may recognize these maneuvers as part of nerve stripping maneuvers or active release technique maneuvers. And so after the fingers are finally extended, if there's no reproduction of upper extremity radiating symptoms, and if tolerable, you can then put the final stretch on those neural tissues by asking the subject to laterally flex their cervical spine away from the limb being tested, thereby completing the stretch on the neural tissues. And as you're sitting there at your desk, doctors, or perhaps if you're listening to this when you're in your car, you can try this maneuver yourself. Simply stretch your fully extended arm out behind your body in the frontal plane and laterally flex your neck opposite to the side opposite, contralaterally, and you'll feel the stretch of neural tissues up through your shoulder and up into the cervical spine. Well, in the case of nerve root compromise, this will provoke symptoms. So with the upper limb tension test, as the progressive stretch is performed, the subject may report reproduction of symptoms such as pain, paresthesias, or numbness in the upper limb. And the indication as to the severity of the problem really is evident in the amount of elbow extension tolerated by the subject as compared to the amount of elbow extension that they're able to tolerate on the other side. So there's a couple of cervical spine nerve root tension signs. What about the thoracic outlet maneuvers? Let's talk here a little bit about the thoracic outlet syndrome, and thoracic outlet physical examination maneuvers. Now, technically, the thoracic outlet refers to the superior thoracic aperture, in other words, the upper portion of the rib cage. Now, the superior thoracic aperture is bordered posteriorly by the first thoracic vertebra. It's bordered laterally by the first rib, and it's bordered anteriorly by the costal cartilage of the first rib and the superior border of the manubrium. And you can probably picture that in your mind. And for those of you that have the PowerPoint presentation, I have here a diagram of the superior thoracic aperture. Now, in addition to the bony boundaries that I've just described, when we're talking about thoracic outlet syndromes, we also have the clavicle to deal with, and we also have the muscular structures above the superior thoracic aperture, all of which can cause complications and compressions of nerve roots, resulting in the clinical syndromes that we refer to as thoracic outlet syndrome. Now, the clavicle is an important player in thoracic outlet syndromes. The clavicle articulates with the manubrium of the sternum, and it forms the anterior border of the thoracic outlet. And the clavicle attaches to the manubrium at the clavicular notch, while the first rib attaches slightly inferiorly. And these are important anatomic landmarks because the clavicle and the first rib create a very small space between them, through which a lot of delicate and sensitive neurologic and vascular structures have to pass. Now, above the clavicle and above the first rib, the brachial plexus is located superiorly and laterally, and you can palpate this on yourself. If you simply reach up to your clavicle and palpate the attachment of your clavicle into the manubrium of the sternum, and then just palpate laterally along the clavicle, when you get to about the 1/3 distance distally along the clavicle, if you just move your fingers superiorly into the soft tissue region there above the in the supraclavicular fossa there, that is where the brachial plexus lies. Now, what you're feeling most superficially are muscles, but if you wiggle your fingers around down in there deep, you can feel a cleft between some of the muscles, and you may not be able to feel the brachial plexus, but it's in there. Not very deep, and it's right above the clavicle in the supraclavicular fossa. So we have the brachial plexus, and the brachial plexus emerges between the anterior and middle scalene muscles just superior to the first rib. Okay? So once it passes the first rib, it then passes obliquely and inferiorly underneath the clavicle into the axilla and then down into the arm. So let's talk about the scalene muscles, because the scalene muscles can be one of the sites at which these nerve roots or trunks of the brachial plexus can be compressed. So the anterior scalene has its origin on the anterior tubercles of the transverse processes of the 3rd through the 6th cervical vertebrae. So you can think of the scalenes as sort of an anterior muscle. They attach on the anterior aspects of the tubercles of the transverse processes of C3 through C6. And these fibers then project downward to insert on the scalene tubercle and cranial crest of the first rib. So they sort of angle antero-inferior. Now, the action of the anterior scalene is to elevate the first rib, so it's actually an accessory muscle of respiration, and then also to laterally flex the head to the same side. So the left anterior scalene laterally flexes the head left, the right anterior scalene laterally flexes the head to the right. Now, acting bilaterally, the anterior scalene muscles would cause flexion of the cervical spine, and acting unilaterally would cause rotation of the head towards the opposite side. So when you rotate your head to the right, that is the action of the left anterior scalene. When you rotate your head to the left, that is the action of the right anterior scalene. The middle scalene has its origin on the posterior tubercles of the transverse processes, now of the 2nd through the 7th cervical vertebrae. So it has a little bit larger and a little bit broader origin than the anterior scalene. Anterior scalene is C3 through C6. Middle scalene is C2 through C7. The middle scalene inserts on the first rib, on the cranial surface between the tubercle and the subclavian groove, and so the middle scalene attaches slightly posterior to the insertion of the anterior scalene. Okay, so sort of a continuum along the length of the first rib. First we have the insertion of the anterior scalene, and then we have the middle scalene. The action of the middle scalene is to elevate the first rib and laterally flex the head to the same side. So that's pretty much the same as the anterior scalene. And then acting bilaterally causes flexion of the cervical spine, and acting unilaterally causes rotation towards the opposite side, similar to the anterior scalene. For those of you that have the PowerPoint presentation, have a diagram here that shows the scalene triangle bordered in the front by the anterior scalene, bordered in the back by the middle scalene, and the neurovascular structures passing between small cleft in between the anterior and middle scalenes, and then projecting below the clavicle but above the first rib. So you'll see that this is indeed quite a tight compressed space, and it's amazing that we don't have more cases, clinical cases of thoracic outlet syndromes when you consider the amount of structures that are compressed into these small spaces. And for those of you that have the PowerPoint presentation, I have here a diagram, complements of primal pictures, that shows the relative insertion points of the anterior and middle scalenes. And you can see the small space, the small cleft in between the anterior and middle scalenes, through which a lot of neurovascular structures have to pass. Now, impingement of the brachial plexus in the region of the scalene muscles, in the region of the first rib, in the region of the clavicle, and even more distally, as we'll talk in a minute, even more distally in the case of the pectoralis minor muscle, these are responsible for what are referred to clinically as the thoracic outlet syndromes. Now, thoracic outlet syndrome can affect one or more of the nerves of the brachial plexus and or blood vessels that supply the upper limb as they pass between the chest and the upper extremity. The blood vessels include the subclavian artery and the subclavian vein. However, involvement of the subclavian vein is rare because it does not normally pass through the scalene hiatus. In fact, the subclavian vein typically passes on top of the clavicle and does not pass underneath the clavicle, between the clavicle and the first rib. Now, thoracic outlet syndrome may result from a positional cause, for example, by abnormal compression from the clavicle and the shoulder girdle with various types and repetitions of arm movements. There are also several static forms or static causes of thoracic outlet syndromes. For example, can be caused by abnormalities, enlargement, or spasm of the various muscles surrounding the blood vessels and/or the brachial plexus. Can be caused by a fixation or a malformation of the first rib, perhaps secondary to a rib fracture with a healed enlarged callus, perhaps. Can also be caused by, for example, a cervical rib, which would occupy space within the scalene hiatus, as would enlargement of the transverse processes of the C7 vertebra. So that gives you a clue to some of the radiographic findings that you might suspect in the case of a bona fide thoracic outlet syndrome. Might see deformity of the first rib, might see the presence of a cervical rib, might even see an enlargement of the transverse processes of the C7 vertebra. Now, as far as workers' compensation cases and in the work that we do as qualified medical evaluators, the most common causes of thoracic outlet syndrome include physical trauma and repetitive stress. Physical trauma might include such types of injuries as would occur in a car accident. Repetitive stress injuries could be due to, for example, frequent or constant use of a non-ergonomic keyboard and desktop setup. We may also see thoracic outlet syndromes in sports-related activities, and then we may see thoracic outlet syndromes in cases where there are certain anatomic defects, such as having an extra rib. Now, examination maneuvers that we will use to confirm or rule out the presence of thoracic outlet syndrome include the Adson's test, the Halstead's test, the costoclavicular maneuver, the hyperabduction maneuver, and the hands-up test, also known as the elevated arm stress test, also known as the Ruse test. Okay, so let's first talk about Adson's test and Halstead's tests. And the philosophy of these tests is designed to determine, the purpose of these two tests is to determine if the compression of the neurovascular structures is taking place at the scalene muscles. That is the purpose of the Adson's and Halstead's tests. And really what these tests do is they begin at the most proximal potential site of compression, in this case is at the scalene muscles, and then testing proceeds distally to include the first rib, the clavicle, and then finally possible or potential compression underneath the pectoralis minor muscle. So let's talk about these tests here one at a time. So first let's begin with Adson's test. Adson's test is used to assess for compression of the neurovascular structures secondary to a space-occupying lesion in the scalene hiatus, such as due to a cervical rib, or due to abnormalities of the scalene musculature. And you might think to yourself, well, what kind of abnormalities could exist within the scalene musculature? Well, there could be many. There could be hypertrophy of the scalene musculature. There could be scar tissue deposition in the scalene musculature. There could be anomalous development of the musculature which narrows the passageway between the anterior and middle scalene. And so many different types of possibilities exist, and Adson's maneuver is one way to test for such abnormalities. So to perform Adson's maneuver, the examiner palpates the radial pulse while extending and externally rotating the shoulder. Then the subject is instructed to take a deep breath and hold it for a count of 10. Now, what's the purpose of taking a deep breath and holding it for a count of 10? Well, the purpose of taking a deep breath is to elevate the first rib through contraction of the anterior scalene muscle and also the middle scalene muscle. So the deep breath causes a contraction of that muscle, causes an elevation of the first rib, thereby narrowing the costoclavicular interval and also shortening the length of the scalene muscles. Then the subject's head is extended and rotated toward the side being tested while the examiner continues to palpate the pulse. A diminution or disappearance of the radial pulse and or a reproduction of the patient's symptoms, and we're talking about radiating upper extremity symptoms, is considered to be a positive result for thoracic outlet syndrome. Now, this is one of these tests that we use, and a positive finding on this maneuver is suggestive of thoracic outlet syndrome. However, the definitive diagnosis for thoracic outlet syndrome cannot be made simply by the finding a positive finding on this maneuver. And I did some research on the validity, inter-rater and inter-examiner reliability of the Adson's maneuver, and I quote for you here a study published in the journal Pain Physician in April 2003 entitled Provocative Tests in the Cervical Spine Examination. And I quote from the authors who claim that, quote, not even tentative statements can be made with regard to inter-examiner reliability, sensitivity, and specificity based on the existing literature. So, a positive finding on Adson's maneuver is simply one suggestion of the possibility of thoracic outlet syndrome. However, it cannot be relied upon for the definitive diagnosis. Now, Halstead's test is performed similar to Adson's test. In fact, it's exactly the same. Although with Halstead's maneuver, the examinee is asked to rotate their head opposite to the affected side, thereby further contracting down the scalene muscles. A diminution or disappearance of the radial pulse and or reproduction of the patient's symptoms is a positive result for thoracic outlet syndrome due to compression at the scalene muscles, perhaps due to some abnormality or malformation of the scalene muscles. The costoclavicular maneuver, also known as the at-attention test, directs our attention now a little bit more distally away from the scalene muscles by attempting to reproduce compression at the costoclavicular interval. Now, to perform this maneuver, begin with the examinee seated and place their arms at their side with palms facing forward. Then you, as the examiner, pull down and back both shoulders in the positions that would occur if they were standing at attention, or, for example, if they were carrying a backpack. Purpose of this is to depress the clavicle and compress the clavicle down onto the first rib. Then ask the examinee to hyperextend the neck and head, thereby increasing the stretch on the scalene muscles, thereby pulling up on the first rib and further narrowing the costoclavicular interval. Any change in blanching of the hands, decrease in the radial pulse, or an increase in the symptoms, meaning radiating upper extremity symptoms, is a positive finding. Now, when we talk about palpating the radial pulse, the radial pulse, remember, is a downstream branch. The radial artery is a downstream branch of the subclavian artery, and it's the subclavian artery that passes through the costoclavicular interval. So from the subclavian artery then becomes the axillary artery. Axillary artery becomes the brachial artery, and then the brachial artery bifurcates to give us the radial and ulnar arteries. So palpating the radial pulse evaluates the presence or absence of compression on the subclavian artery. Okay, the hyperabduction maneuver. This maneuver is performed in cases where the entrapment of the neurovascular bundle is suspected to be even more distally now, beyond the costoclavicular interval. Now, the neurovascular bundle, as it passes through the axilla, passes underneath the pectoralis minor muscle. And the pectoralis minor muscle attaches to the coracoid process of the scapula. And you may remember from anatomy that there are three muscles that attach to the coracoid process of the scapula. They are, number one, the coracobrachialis, number two, the short head of the biceps brachii, and then number three, the third muscle, is the pectoralis minor muscle. So there's a lot of activity taking place right around this coracoid process. And the neurovascular bundle can be compressed underneath the tendon of the pectoralis minor muscle as the neurovascular bundle passes immediately underneath the coracoid process. So to perform this maneuver, the upper limb being tested is placed and maintained in a position of shoulder hyperabduction, and sometimes this is called the hyperabduction maneuver. The eponym is the Wright's maneuver with a W, W-R-I-G-H-T, Wright's hyperabduction maneuver. So the shoulder is placed and maintained in a position of hyperabduction and external rotation. Meanwhile, you palpate for any changes in the radial pulse, which would indicate compression of the subclavian artery as it passes underneath the pectoralis minor muscle. So positive finding for the hyperabduction maneuver would include any change in blanching of the hands, decrease of radial pulse, or an increase of radiating upper extremity symptoms. All would be considered positive findings for compression at the pectoralis minor muscle. Then finally, we have the hands up or the elevated arm stress test. And again, this is a test designed to assess for compression of the neurovascular bundle as it passes beneath the pectoralis minor muscle. And to perform this maneuver, the subject either sits or stands with both shoulders abducted to 90 degrees and maximally externally rotated. Elbows flexed to 90 degrees to look like the hold 'em up or stick 'em up position. And then the subject slowly opens and closes the hands for a 3-minute period. A positive test for thoracic outlet syndrome here is indicated by, number one, the inability to maintain the upper limb position, Number 2, ischemic pain, numbness, paresthesia, and number 4, heaviness of the arm. And I don't find this personally to be a very valuable test because I think symptoms could be reproduced in many normal subjects by having them hold their arms up for a period of time of 3 minutes. And if you want to confirm this for yourself, I ask you to go ahead and hold your arms up in the stick 'em up position for a period of time of 3 minutes and let me know what types of symptoms you experience.